Hello, and thank you for joining us. The Southeast Mental Health Technology Transfer Center is pleased to present today's webinar event, Updates on First Episode Psychosis. My name is Stephanie Tapscott, and joining me in moderating today's event is Dr. Benjamin Druss, Director of the Southeast Mental Health Technology Transfer Center. Before beginning, I would like to take a moment to describe the work of our center, and Dr. Benjamin Druss will introduce today's speaker. The Southeast Mental Health Technology Transfer Center is located in Atlanta, Georgia, at Emory University's Rollins School of Public Health. We are proud to serve the 8 states in HHS Region 4. Our expertise in public health programs, systems, research, and evaluation provides a unique lens through which we can address mental health priorities. The goal of the Southeast MHTTC is to accelerate the adoption of evidence-based mental health programs by providing training and technical assistance to Region 4. We use a public health approach to build leadership capacity and to provide mental health trainings and resources to providers, agencies, and communities across the Southeast. We encourage you to visit the Southeast Mental Health Technology Transfer Center website to learn more about our center and our upcoming events.
Hello, it's really my pleasure today to introduce Rob Cotes. Rob is an associate professor at the Emory University School of Medicine in the Department of Psychiatry and Behavioral Sciences. He attended West Virginia University School of Medicine, then completed his psychiatry residency at Dartmouth. He serves as co-director of the P-STAR Clinic, director of Project Arrow, and co-director of Open Dialogue Atlanta at Grady's Outpatient Behavioral Health Clinic. The P-STAR Clinic provides evidence-based, recovery-oriented care for individuals with persistent symptoms of psychosis, specializing in the use of clozapine. Project Arrow is a coordinated specialty care team for people experiencing first episode psychosis, offering comprehensive, person-centered care using a multidisciplinary approach. His research focuses on clozapine, cardiometabolic side effects of antipsychotic medications, digital biomarkers, and first episode psychosis. Dr. Cotes is the principal investigator for multiple clinical trials focused on treatment options for psychosis. He serves as psychiatrist expert for the American Psychiatric Association's SMI Advisor Initiative. Rob, we're really looking forward to your talk today. I'll turn it over to you.
Thanks so much, Ben. It's really a great honor to be here today. I'm joining everyone here from my office today rather than my home, where I have a number of young children and an inflatable bouncy house, and sometimes there's a Roomba that sort of vacuums around. So this is going to be a little bit more, hopefully, of an uninterrupted presentation. Let me just share my screen here. Okay, great. So hopefully my slides are up. We're going to be talking about first episode psychosis today and some recent updates. Let's see, some disclosures here. I think the most relevant disclosure is that we received research funding from Otsuka Pharmaceutical, and we'll be talking a little bit about the Prelapse study later, which we were part of, and it's about long-acting aripiprazole for people with first episode psychosis. A couple of learning objectives for today. So after you leave today's talk, I would like you to be able to describe 3 strategies that engage young people who experience psychosis, be able to summarize the benefits of reducing the duration of untreated psychosis, and then finally to list the key personnel on a coordinated specialty care team. And trick question, that might depend on where you are and what kind of CSC team you're a part of. So this is going to be an overview, a non-comprehensive one of what's going on in the early psychosis world. And it's going to be broken up into a couple different parts. So first we're going to talk about engagement. Then we're going to look at the natural history of schizophrenia and early psychosis. And we're going to talk a little bit about a staging model. And then at the end, we'll talk about coordinated specialty care services and what we know about them. And then we'll talk about a few caveats regarding medication, because sometimes questions come up about medication frequently on a CSC team. So before I started working in an early psychosis team, I had worked on an inpatient unit at Grady Hospital for 8 years. And I was always very interested in what could we do to ensure that people, after they left the hospital, got adequate services. And engagement is a major, major issue, I think, within mental health and for people with first episode psychosis specifically. This is from some data that was just published looking at people who received no treatment within the past 12 months. You can see 55% of people with any mental illness received no treatment, and then 35% of people with severe mental illness received no treatment. If you break that down by age, you can see that young people were more likely to not receive treatment than people who were a little bit older. And I think that that speaks to some of the engagement challenges of working with younger people. This is some of the reasons from SAMHSA. About half of people perceived that there was an unmet need for mental health services. Some of the reasons were couldn't afford it, didn't know where to go, thought that they could handle it without treatment, were concerned about having to go back to the hospital, and then some people just thought that treatment wouldn't help. So people are really able to fall through the cracks in a number of different ways. And a lot of times there's first of all, there's not everybody receives mental health treatment in the first place. And then there can be a disconnect between inpatient and outpatient follow-up rates. And then for people who are in outpatient services, many don't come back after the first visit. So just to highlight a little bit of data from Grady, we currently on our inpatient unit have about 50% of people that are supposed to be going to outpatient services actually make it. So that means that we need to do a better job of communicating what outpatient treatment is about and how we can be helpful. And that's slightly lower than the median outpatient rate in the literature in a meta-analysis. So who are the demographic characteristics of people who become disengaged from treatment? And a lot of these characteristics here are exactly the kind of people that we work with on our first episode team. So young age, male gender, ethnic minority, low social functioning, social isolation, low SES, and unemployment. And then what do people who are disengaged from services say about why? A lot of this has to do with the way that they've perceived the mental health system and the kind of treatment they've received. So unsympathetic providers, not being listened to, not being able to actively participate in shared decision-making, and being dissatisfied for services. And I think that it's really these perspectives that are at the center of what's important in developing first episode services. So what can we do about it? Well, a number of things. First of all, it's important that an entire system has a culture of recovery. After that, there's certain system approaches that may help to improve engagement. And then if you're a frontline clinician, there's things that you can do as an individual to help as well. Now, I think that everybody is sort of aware of this, but I'm just going to go over recovery very quickly. One definition from SAMHSA is that it's a process of change through which individuals improve their health and wellness, live self-directed lives, and strive to reach their fullest potential. And in the mental health setting, we are not the judge of what someone's fullest potential is. That's not for us to decide. Our goal is to help people get to where they want to be. I just want to contrast the medical model very briefly from the recovery model. In the medical model, treatment really is to help improve symptoms, and it's the improvement of symptoms that is what leads to wellness. The recovery model is conceptualized a slightly different way. It all starts with where one is and then what somebody's goals are. Obviously, there's steps that need to be taken to get there, and obviously there's barriers that get in the way. And in the recovery model, treatment comes in to help overcome the barriers that get into people's way of accomplishing their goals. So a couple of system-wide type things that can be used to enhance engagement for young people. At the bottom is more lower intensity. Then we have things like case management, and then the higher intensity interventions include assertive community treatment and coordinated specialty care. So an example of linkage services are things like minimizing wait times, making appointments for clients, reaching out if somebody misses an appointment, helping to, introduce someone who's in the hospital to the outpatient team. So just like very basic kind of things can actually make a big difference. So there may be some of these things that you can change in your system, and there may be some of these things that you can't change in your system. But what I wanted to do was highlight a couple of things that you can do as an individual that you can use to help engage people that you work with, especially young people with first episode psychosis. So it's important to realize that one approach isn't going to work for everybody, and that you might have to take a number of different approaches, and the approach that you might take for the same individual might change over time. It's so important that you have to be creative, and you have to have fun. Very important too is to really have a merging of your agenda and what somebody comes to see you with. I think if you just have an interaction with someone and kind of it's all about your agenda, I think that's really good. That has the potential of maybe turning somebody off from services. Then I think working with people with first episode psychosis, it's important to take your time and really budget extra time if you can. It often takes longer than you initially think that than you might set out to. And then the important thing is never take someone returning to see you for granted. And that if somebody comes and spends parts of their day in mental health treatment, it's really important to respect that and to really give people an opportunity to come back to services and communicate the value that services may bring to them. So I was talking with a young man with early psychosis yesterday. His father was with him. We all sat down in this room, and his father kind of started off the meeting and talked about a lot of things that had been going wrong. And some of the symptoms that he was having. And then he said, now that I've gotten that off my chest, I'm going to step out for a second. And it was just a young man and I there, and we were like, okay, let's go play some ping pong. And we just got up and we just played some ping pong together for about 10 minutes and just kind of chatted a little bit. And that really helped, I think, him to open up a little bit more and be in a situation where he didn't feel like he was going to be judged. Next, we're going to talk a little bit more about some engagement strategies. Check your ego at the door, because sometimes when you're working with people for whatever reason, you just might not have that connection with them. So I often like to find the person on the team that has the best rapport with someone or the best alliance and really work closely with that person. Sometimes it's me, and a lot of times it's not me, and that's okay. I think we do a great job sort of assessing for people's goals, but also you want to assess for people's interests. That way you can really have a common ground. Engaging the family is really critical. And then also every opportunity you can, instilling hope. Someone just the other day told me about an experience she had where I told her about someone who had a diagnosis of schizophrenia who went on to do great things. And she remembered that from 5 years ago and said how uplifting that was, and she ended up accomplishing all kinds of things. So it really makes a difference. And then also it's important to have a genuine interest in what people are interested in, and whatever they're interested in, they can help to describe to you what that is, and they can and they can sort of show you your expertise. And I've learned a lot about a lot of different things over the years from working with young people. then it really also takes a genuine interest in somebody's experience, inner experience. And that means a curiosity about how people feel, think, maybe even about some of the symptoms they may be having. So this is tough, and it's even tougher during COVID-19, where we can't see people as frequently in person. And we can talk a little bit more about how engagement has changed in the Q&A, if we have time. So I want to talk now a little bit about first episode psychosis specifically. And it's important to kind of think about this in a neurodevelopmental framework. And this is a graph that I'm sure everybody is familiar with. There's different stages. In the beginning, there is a pre-morbid stage where people have few or no symptoms. Then there's a prodromal stage. And then there's kind of a first episode of psychosis stage here. And then there is sometimes a relapsing remitting course. There's a really heterogeneous course about what happens with people's symptoms after the first episode. So I thought it would be important to kind of take a look at this from a proposed staging model, 1, 2, 3, and 4. And really, we're going to spend most of our time on stage 2, full threshold FEP. But I'm going to talk a little bit about what's up in the asymptomatic genetic risk category, and then a little bit about the clinical high risk work that's being done. We're not really going to focus on stage 3 and stage 4. So asymptomatic genetic risk. It's important to have an understanding, especially if people ask you, you know, if somebody's thinking about maybe having a family and they have a diagnosis of schizophrenia, what's going to be the risk to their kids? So the genetic studies that have been done help to give us a sense of that. You can see that there's strong genetic loading that happens, fraternal twins and identical twins. So if somebody has schizophrenia and an identical twin, the risk that their identical twin is going to have schizophrenia is 48%. Okay, so what about environmental risk factors? There's been a number of them that have been looked at over the years. A lot of the common denominators here are stress. So stress may activate the immune system, which may put people at an increased risk to develop psychosis later down the road. There's a number of risk factors that are important and have been studied, especially recently. Cannabis heavy use, for example, is one, and that has an odds ratio of 3.9. There was some work that was done at Grady that looked at by Dr. Michael Compton, that looked at the progression of cannabis use, people going, for example, from weekly cannabis use to daily cannabis use, were found to have an increased risk of developing psychosis. Difficult questions to unravel, chicken or the egg type issues, but it does look again and again like heavy cannabis use, especially in the puberty and the at-risk period, may have a risk of increasing the progression to psychosis. So what do people do for people who have an asymptomatic genetic risk? There have been some candidate interventions that have been studied, prenatal choline, school-based interventions. This includes things like reducing bullying, giving people coping skills. Some school-based interventions have even been around reducing substance use. Next is N-acetylcholine. Polyunsaturated fatty acids have been used, prebiotics, exercise training. And really, all of these things seem to be good to do, but there is not at this moment sort of in a definitive way to prevent people with an asymptomatic genetic risk from developing an episode of psychosis later down the road. Now I want to talk a little bit about the work that's been done in the clinical high risk area. This is a little bit confusing because there's a lot of acronyms that are used for people in clinical high risk, and we'll just go over a little bit about what those are. So as I had shown you before about that graph on the progression of what schizophrenia may look like, there's also a progression sometimes of what happens within the prodrome. And that can be divided into what's called basic symptoms, attenuated positive symptoms, and blips. So attenuated positive symptoms are sub-threshold positive symptoms of the illness that occur usually once per week within the past month. And they're brief. And then people who have attenuated positive symptoms, you can see that the risk of transition to psychosis is 19% at 2 years. And then the next one that's a little greater risk is the blip, and that's called a brief limited intermittent psychotic episode. Those are usually transient psychotic symptoms, and they can last 4 days per week over a month. The onset is usually within the past 3 months. And it's very specific rating scales that help you to figure out if somebody's having attenuated positive symptoms or blips. One of the most commonly used is called the SIPS. And the SIPS is kind of a challenging instrument to administer, and it takes a little bit of practice kind of using it. It's not routinely done in clinical practice. So for people who meet clinical high-risk criteria, the people that convert into psychosis is generally between 20 to 35%. And it really depends on what the setting is, and it depends on the criteria for clinical high risk that's being used. Generally, these individuals are help-seeking. So these folks or their families kind of notice that something's wrong, they're not feeling right. They then seek out the help of a clinical high-risk program. They do an assessment, and then it's between 20 to 35% of these people who convert into a first episode of psychosis. There's been a lot of work that's been done in this area, and some really important work has actually taken place in a collaboration that Emory's part of called the Naples Consortium. And I just wanted to highlight this very briefly, and certainly it's not going to do full justice to all the work that they've done, but in Naples 2, this is the second iteration, the conversion rate of 596 clinical high-risk individuals was 16%. Predictors to transition included higher levels of unusual thought content, greater decline in social functioning, lower verbal learning and memory performance, slower speed of processing in younger age, and then they developed this cool risk calculator that's mostly been used for research. And you can see the risk calculator here. The website is up there for you. People actually have to have a SIPS administered by a professional in order to get and they actually have neuropsych testing in order to look at this. So what interventions have been used in the prodrome? A number of clinics called Clinical High Risk for Psychosis Services have been developed. One of the examples is called PEER, which was developed in Portland, Maine. Another clinic like this is STEP, which is at Yale. And then SAMHSA has actually supported various clinical high-risk services for the states. There's definitely not as many as first episode teams, but I think that this is really the future, is sort of these clinical high-risk teams, because you can really reduce the duration of untreated psychosis. So some other interventions that have been used have been multifamily groups, long-chain polyunsaturated fatty acids, cognitive behavioral therapy, and pharmacotherapy. So pharmacotherapy is the idea of someone in the clinical high risk actually being prescribed an antipsychotic medication and seeing if that reduces the risk to psychosis. And generally in these studies, it turns out that medication may delay for some people the transition to psychosis, but it doesn't appear that medication in the clinical high risk will prevent the conversion of psychosis. And medications have a lot of risks. And then for people in clinical high risk, 20 to 30% of them will transition to an episode of psychosis. So it's a high risk strategy sometimes to use an antipsychotic medication in the clinical high risk phase. Okay. An example of a study that's been done like this is the NeuroPro study. And this was a randomized double-blind study in which people either got placebo or they got polyunsaturated fatty acids. And they actually found no difference in the transition rate for people who went to psychosis or not. I want to talk a little bit more about now the first episode of psychosis. For most people, men tend to experience symptoms a little bit earlier than women do. And you can see that there is an interesting second peak for women who have a first episode of psychosis that's usually in the later 40s. That may have something to do with estrogen having a protective effect on psychosis. Okay. Now, in the first episode treatment world, I think that reduction of the duration of untreated psychosis is a key variable to help to mitigate. And it's interesting because duration of untreated psychosis does correlate with some things, but it may not correlate with other things. So we know that a long DUP is associated with poor general symptomatic outcome, more severe negative and positive symptoms, less likelihood of remission, poor social functioning, but it is not associated with employment, quality of life, or hospital treatment, at least in this recent meta-analysis. I want to talk a little bit about the stability of the diagnosis, because when people have a first episode of psychosis, sometimes the diagnosis can be very unclear, and sometimes it may take a few months to really get to know someone to understand what the diagnosis may be. This was a meta-analysis that followed people for 4.5 years that looked at how the diagnosis changed over time. And when people had a diagnosis of schizophrenia, the point estimate diagnostic stability was 0.9. So that means that 90% of people at the follow-up period continued to have the diagnosis of schizophrenia. So once people made that diagnosis, they were often pretty sure that that's what it was. It didn't change to many other things. I want to just take a quick look here at schizophreniform disorder, because this is an interesting one. Turns out that 0.57% of people with schizophreniform disorder ultimately develop schizophrenia. Also, you can see how substance-induced psychosis changed over time. You can see how brief psychotic disorder changed over time. A lot of people still have brief psychotic disorder. All right, so the next part we're going to talk about is the services for people with first episode psychosis. I think that what has happened recently has been a really incredible example of reducing the bench to bedside time. So the NIMH launched an impressive program to study first episode teams and then to implement them across the country in a way that happened much more quickly than most services are implemented in the community. So we know that early intervention services are helpful. And in a meta-analysis that was done 2 years ago that included 2,100 individuals, early intervention services had better outcomes on symptoms, hospitalizations, improvement in work and school, and every single variable they looked at. Now, the APA, the new guidelines for schizophrenia just came out later, I guess it was last year, and they recommended that people with schizophrenia who are experiencing a first episode be treated in a coordinated specialty care program with a recommendation of 1B, which is a very high level of confidence and a strong recommendation. So what are the different roles within coordinated specialty care teams? This depends on the different coordinated specialty care team you're a part of and may have to do with the kind of people that you may work with, and there may be certain components that, that may be more important to include. But anyway, there's a number of different models that you may have heard of called Navigate, On Track New York, STEP, ISA, the Race Connection program is another. And I have here, in the middle is the person. And then on the outside, we have the different roles. So those roles include case management, low-dose medication management, individual therapy, usually that's CBT for psychosis, or individualized resiliency training, connection with primary care and nursing. Some of the things that is really most engaging for folks is the supported employment and education. That's getting people back to work or school. Family education is critical. In our program, Project Arrow, our peer support specialist is, I mean, incredible. And I think we've all learned so much from our voices with lived experience. And, you know, our peer specialist really connects to other people in a way that many people on our team just aren't able to. And then interestingly, in the state of Georgia, we have a family peer support specialist. So this is somebody who's had a loved one who has had psychosis that then is a member of a team and really specializes in working with families. The CPSP role is really important. One of the things that's not on here that could be on here is a substance abuse counselor. And some of this really depends on the setting again. So we talked a little bit about the NIMH's initiative called RAISE. We'll talk a little bit about that data next. So at Grady, we were a part of the RAISE study. It was an interesting cluster randomization design. So that means that some people were randomized to standard care and some people were randomized to the actual intervention. So the site was, not the individual. And their model included many of those elements we just talked about: medication, psychoeducation, resilience-focused individual therapy, and then supported employment and education. And they used a scale of functioning called the Heinrichs-Carpenter as their primary outcome. Now, what they found was duration of untreated psychosis was a key mediator in how people ended up doing. So they took the median duration of untreated psychosis, which was 74 weeks, and then people who were above that versus below that, and they found that really the coordinated specialty care model for people who had a duration of untreated psychosis of less than 74 weeks tended to have a bigger improvement. So that was really important and sort of gets back to this idea of what can we do to reduce the duration of untreated psychosis? And hopefully we see more clinical high risk for psychosis programs popping up. Now, we've learned a lot of other things from RAISE too. And I'll talk about some of those things. You know, the median duration of untreated psychosis was 74 weeks. And it was found that if you divide the United States up into different geographic quadrants, people in the southeastern United States tended to have a longer duration of untreated psychosis than those in northern states, 79 weeks versus 26 weeks. So pretty striking difference. Of all the geographic quadrants, the southern states tended to have the longest DUP. And I think that's an important thing for us to think about in our area of the United States. Why is that? And does it have to do with less number of first episode teams? Does it have to do with stigma? Is it kind of a combination of a stigma and access issue? So a number of factors may be playing into that. The next important point was that half of individuals enrolled in the coordinated specialty care programs had a co-occurring substance use disorder. Half of them. So first episode teams really need to be prepared to work using evidence-based tools to help people who have co-occurring substance use disorders, using integrated treatment for dual diagnosis, using motivational enhancement, taking a non-judgmental approach. All of these things can really be important. The other thing that really struck me that came out of these studies was that nearly half of people who participated in these programs were either overweight or obese. So there was something about the metabolic machinery, and people were only on antipsychotic for mean time of 47 days. So something was already going on metabolically, and we know that young people with early psychosis are very vulnerable to the cardiometabolic side effects of antipsychotic medications, which is why it's so important to choose wisely and to really help people with lifestyle kind of issues. Also, for people in this study, about 40% of them had pre-hypertension and 10% had hypertension already. So medically, there were a number of concerns, and just because people were young doesn't necessarily mean they were, completely physically healthy. In the RAISE study, there was definitely some evidence of disparities, and I think it's really important to talk about those. For example, there were differences in symptoms based on people's ethnic groups in the, this is the CC as the care as usual group in comparison to the navigate group. So in the care as usual or treatment as usual group, non-Hispanic African-American individuals had they had higher levels of positive symptoms, disorganized thoughts, and hostility. But in the Navigate arm, that's the coordinated specialty care, there was no association of race and ethnicity and symptoms over time. But in the Navigate arm, non-Hispanic African-American people were less likely than non-Hispanic white people to actually receive family psychoeducation. And I think that that might give us some interesting information about the cultural competence and the cultural humility of the types of interventions, and really trying to figure out, like, are we really serving the population that we're working with? And you can see the graph here about how people utilize services differently. There were no differences in how people utilized individual therapy, but African-American individuals tended to use the family psychoeducation component of it less. I wanted to present some quick real-world data from the 10% mental health block grant study. And this is real-world data, obviously raises research data. And one thing that I've found is there can be a big difference between people who are enrolled in research studies and then people that you just are working with that are not in a research study. So in the 10% mental health block grant study, this is where SAMHSA evaluated some of the recipients of the mental health set-aside, and they basically found that people did pretty well. There were improvements in Colorado Symptom Index, quality of life score, social scale, role scale. There were some areas of improvement, and that staff turnover was one area that there were some concerns that 60% of sites lost at least 25% of staff. And we'll talk a little bit more about barriers of coordinated specialty care team. And turnover is a big one and can really hurt the team. So a little bit of naturalistic data from On Track New York. In On Track New York, they were able to demonstrate employment and education rates increasing from 40% to 80% after 6 months. And also they found that hospitalization rates decreased from 70% to 10% by 3 months. So impressive in terms of reducing hospitalizations and improving functioning. Now, not everybody who has a first episode of psychosis is treated in a coordinated specialty care team. And I think that's one of the things that SAMHSA is doing with the 10% set aside, is to really get states to develop more of these programs. So if you need to find one of these, there are two treatment locators that you can use. One is on the SAMHSA website. This is the Early Serious Mental Illness Treatment Locator. And then the other one is through PEPNet. And I just sort of took a quick snapshot of some southeastern states, so you can see where the coordinated specialty care teams are actually distributed throughout the U.S. All right, next, I want to talk a little bit about medication. And medication can be a big topic in a first episode team. We just had a family night in our first episode program, and we have different topics, and we try and talk about medication usually 3 times per year if we have a meeting every month. The turnout is usually really pretty good for these. And I think it's important to sort of think about how medication can play a role for someone. What do we know about medicine? What do we don't know about it? In the prescriber role, there are some medications that may be better than others for people with early psychosis. And this is from the PORT guidelines. You often want to select a medicine that has lower risks of cardiometabolic side effects. And it's recommended to typically avoid olanzapine and clozapine in this stage. Olanzapine can be quite effective, but it does have significant side effects of weight gain, and other options may be just as effective. An expectation sometimes that someone might not be consistently taking their medication may be a helpful framework to look at it. You know, a lot of times young people aren't taking any other medicines. They're sort of questioning whether they need to take medicine. Medicine may have side effects. So there's a lot of reasons. And then, you know, of course, everybody who's prescribed medication misses doses here and there. So taking a normalizing and non-judgmental approach is important. There's definitely been new data released on long-acting injectables and how long-acting injectables may mitigate symptoms over time and may mitigate hospitalization. So we'll talk a little bit about that. And then finally, if you're able to, considering a measurement-based care approach can be helpful. One approach that we use is the CRD-PSS, which is found in the back of the DSM-5, which looks at a number of different domains on symptoms, and it really can be pretty quickly done and easily incorporated into the electronic medical record. So back to medication consistency. It's probably a better way to think about it to call it medication consistency rather than compliance. We try to avoid the term medication compliance. Think about long-acting injectables, engage people's families, and then it's important to think about why is taking a medication important to people. And a lot of the approaches that are used are often thinking about how medication can help people accomplish their recovery goals rather than simply ameliorate symptoms. So medication may help someone to remain more focused and concentrated and have better concentration so they can function well at school. Or medication may help someone stay out of the hospital, because I think that one way to partner with people is avoiding being back in the hospital. So there have been a number of studies looking at head-to-head studies of different medicines for people with first episode psychosis. And they differ kind of based on the individual properties of the medicine. This is just an example of one of those, aripiprazole versus risperidone. These folks were followed over 3 months, and there was no difference in response rates when people were taking aripiprazole versus risperidone. So I guess the point of this is there's usually not one best choice for people in a first episode of psychosis about what medication to choose. And then it was demonstrated that aripiprazole in this study had better negative symptom outcomes, more akathisia, which you would expect, and then less cardiometabolic side effects. So long-acting injectables in the first episode are a really important topic. You know, it has been somewhat difficult historically to be able to show that long-acting injectables reduce rehospitalization. And when you look at randomized controlled studies, sometimes there's not a strong signal there. But the more naturalistic you look at it, like the bigger you step back, there can be a benefit shown. So one of the goals of this study was to look at, did a long-acting injectable medication help to prevent people in the first episode of psychosis from returning into the hospital? And we were very pleased to be a part of this study at Grady. This study was looking at people who had less than 5 years of antipsychotic medication, and they used a cluster randomization design. So half of sites were enrolled to using the aripiprazole once monthly, half of sites were treatment as usual. And in treatment as usual, you could actually administer a long-acting injectable. And I think 30% of people in treatment as usual actually got a long-acting injectable. So the main outcome was preventing hospitalization, time until first hospitalization. And they found that basically there was a number needed to treat of 7 to prevent a hospitalization in the aripiprazole once monthly group. So that means if you give 7 individuals a long-acting injectable, you will prevent one of them from having a hospitalization, in comparison to where if you would have just if you would have not given anybody a long-acting injectable. So interestingly, there was also a 44% reduction in the incidence rates of first hospitalization for the aripiprazole once monthly group compared to the treatment as usual. All right, next a little bit about depression and first episode psychosis. The diagnostic clarification is really important and really sort of assessing for depressive symptoms, figuring out if in fact someone has a major depressive disorder with psychotic features, really important. If it turns out that somebody has schizophrenia and they do not have a major depressive episode, it probably doesn't make sense to give them an antidepressant. So the typical guidelines recommend using an antidepressant only when the depression persists and is an ongoing. So the next couple slides I'm going to show you are about what is the relapse rate for people who have first episode psychosis, either taking medication or not taking medication. And this is one of the most common, frequently asked questions that I receive is, how long do I have to be on this stuff? And this is a study looking at a meta-analysis of risk of symptom recurrence if people stayed on medication versus if people went off of medication. And it only included 4 studies in the on-medication group and 6 studies in the off-medication group. And at 1 year, if people were taking medication consistently, there was a 3% risk of relapse. If people were not taking medication consistently, 1 year off, 77% risk of relapse. 2 years off, 90% risk of relapse. So it's important, I think, to give people information like this and say, you know, medication may help to prevent relapse. This is what it looks like. We don't know who is going to be in the 23% of people who do not relapse after a year. We don't know who is going to be in the 10% of people who don't relapse after 2 years. But, you know, overall, this is kind of what it looks like. This was a little bit more recent study that was examining a similar question about maintenance antipsychotic medication versus those who discontinued. And you can see that the maintenance antipsychotic group had a much lower relapse rate than those who had discontinued medication. And at 12 months, there was a number needed to treat at 3. So what do various guidelines have to say about how long should somebody take an antipsychotic medication or not? And the APA practice guidelines that were just released, they basically said people with schizophrenia whose symptoms have improved should continue to be treated with an antipsychotic medication. And they didn't say anything like, after X amount of time, consider not being on an antipsychotic medication. Which is, and if you look at international guidelines about what do different guidelines say about this, there really are varying recommendations. And I think some of this really speaks to the literature and some questions that we really don't know the answer to quite yet. So some of the recommendations were between 1 year to 5 years, and some groups made no recommendations. So there was a recent paper that looked at this about when could somebody come off their medications, and it was a little bit more of a nuanced kind of conversation. Zapersky basically recommended that maintenance treatment should be continued until the diagnosis is established with confidence, which can sometimes take time, as we mentioned. And there can be really some uncertainty about that, especially in the beginning. They recommend that for people with schizophrenia or schizoaffective disorder, maintenance antipsychotic medication should be continued. They recommend that if somebody has had a complete remission of symptoms, patients and families should have a complete understanding of the risks of medication discontinuation. Then people who had a first episode that was associated with high risk of harm to self or others maybe should be discouraged to try a trial off of medication. And then if someone were to pursue a trial off of medication, it should be done so gradually with support of the team and continuing for at least 3 years. So another thing that's been very important in sort of first episode work is recognizing when someone is not responding well to an antipsychotic medication. The vast majority of people with first episode psychosis respond well to antipsychotic medications, and they can do so at lower doses, usually between half to a third of the usual maintenance dose. Someone can do really quite well on first episode psychosis. But first episode teams are increasingly recognizing if people aren't responding to antipsychotics and going to clozapine more swiftly. As ever, clozapine is really underutilized in the United States, and it's thought that between 20 to 30% of people with schizophrenia could actually benefit from clozapine. The problem is there's often a long delay until people likely could benefit from clozapine to the time that they're actually started on clozapine. And the APA guidelines, the ones that were just published, suggest that after 2 antipsychotic failures, then it's really time to start thinking about clozapine. So this was I thought a pretty important study that was looking at, what happens after somebody doesn't respond to an antipsychotic medication, and when is it time to really start thinking about clozapine? So this is called the Optimize study that was done in Europe, and it was using a medication that we don't have in the United States called amisulpride. In phase 1, it was open label. People for 1 to 4 weeks everybody got amisulpride. And in phase 1, 56% of people had a symptomatic remission. In phase 2, it was double-blind, amisulpride or olanzapine, and this was from weeks 5 to 10. You can see if you kept somebody on the same medication, there was a 45% chance of achieving symptomatic remission versus changing them to olanzapine was 44%. So not much of a difference there. Phase 3 was open label clozapine. So if somebody didn't respond, then they got a trial of clozapine. And there were 30% of people there, close to 30%, who achieved symptomatic remission. So I want to just very briefly talk a little bit about coordinated specialty care challenges. And there was a recent review article published in Community Mental Health Journal that was talking about some of these things. Right now, we have the Mental Health Block Grant, which has been extraordinarily helpful in making these teams more widespread. But staff turnover is a major, I think, threat. And after you lose somebody, it often takes time to hire somebody and then train somebody and then really start to develop the rapport with the young people and really get up to speed. So a lot of time can be lost in staff turnover. Engagement and disengagement is also a major barrier. There are some people who are extremely challenging to reach, even despite using coordinated specialty care, being really creative, doing everything that we possibly can. And then I think we need to sort of look individually at our teams and the kind of people that we're serving, and are we providing culturally appropriate services for them. Okay, so that was the end of my prepared remarks, and I thought turn it back over to Ben.
Thanks so much, Rob. What a wonderful kind of practical presentation. I learned a ton, so thanks. So now we have just a few minutes for questions. Would encourage people, if you have any questions, reflections, put them in the chat, and we'll keep an eye on them and answer. Encourage both people who might. I'm expecting there may be people out there who are actually working in specialized settings. Also, those who may not be, but trying to do this work. Rob, I wanted maybe to lead off. You had mentioned that maybe we could talk in the question and answer about COVID. And I'm just wondering if you have any reflections on kind of what pieces of what you've been talking about translate to a virtual setting, which ones are harder to do, and what you see, moving forward in the next 6 months to a year, what you see some of these services looking like.
Yeah, thanks, Ben. I think that's a really great question. On our team, for example, in Atlanta, we had had a long-standing hope to transition to be able to reach more people virtually. And we were sort of working on this in January. 2020 and February 2020 and really weren't getting anywhere. And then in March, everything changed. You know, we had to do it right then. And, you know, I think I'm a part of two programs. One is kind of a first episode program, and one is a program in which a lot of people are taking clozapine. And typically in the first episode program, people are a little younger. And many people were really quite savvy to be able to connect via Zoom or via other telehealth services. Initially, we also found it a little bit easier to engage family members as well. And there were some barriers that were maybe made a little bit easier to overcome in terms of, you know, kind of coordinating an appointment and sort of dealing with the Atlanta traffic, and just a lot of things sort of practically happened. So initially, there was a lot of engagement. It was a pretty easy transition. There was sort of digital and, you know, digital groups that were going on, sort of changing the program from in-person groups to digital groups, and trying to figure out what would be a better digital group was one of the challenges. I think we found that that the peer-to-peer group was a really excellent group that kind of continued virtually. And then we had a DJ for a day group that continued virtually, in which people sort of played music and sort of talked about different music that they were into. And, you know, people really liked the idea of, you know, kind of controlling the Spotify playlist and sharing what kind of music they were into. So, you know, I think that looking forward, I anticipate many teams will have a hybrid of in-person and digital type services. We have definitely needed to sort of continue to see some people in clinic periodically, especially if an internet connection wasn't great, or if there were some movement side effects that we need to take a look at. But I think that one of the downsides was our sort of individual and family space. We really weren't able to leverage anymore. Like you know, there was no way to kind of play PS3 on the PS3 that we had, and then sort of play table tennis on a. So we definitely missed that. So yeah, those are a couple COVID-related thoughts.
Thanks. Wonderful. So, I mean, I'm not sure that we're going to have time for other questions. I want to make sure there's time for any other housekeeping to do at the end. A few of the questions around getting, you know, access to slides, those will be available on our site. But just wanted to, again, thank you so much. This was really wonderful. And, you know, I'm grateful on behalf of our center and our region. Thank you so much, Rob.
Thanks so much, Ben. Great to be here. Thanks, everybody.
The Southeast Mental Health Technology Transfer Center thanks you for your participation in today's event. We value your feedback and invite you to evaluate this event. Please complete a brief SAMHSA required survey by visiting the link presented on this screen. Completion of the survey will provide information to SAMHSA and assist us in planning future events. Afterwards, you will be automatically redirected to additional questions from the Southeast MHTTC regarding the impact of this event on your knowledge and skills. There you will have the opportunity to download a certificate of attendance for your records. Please allow a few seconds for your browser to redirect you to the second survey. Again, our center appreciates your participation and feedback. We hope you will join us for future events. Please visit our website to learn more and to view an on-demand recording of this presentation in a few days. This concludes today's presentation. Thank you so much.